Hi everyone. Can everyone hear me? With or without the mic? I'd like to avoid standing at the podium if I can. We're all coming from lunch, right? So I think most people who want to be here should be here. So it's kind of intimate. Feel free to move up if you'd like. I introduced myself earlier. For those of you who weren't here, my name is Pravin Rao. I'm here from Baltimore, and I'm at Johns Hopkins in the Department of Urology there, and I specialize in male infertility. So I treat all sorts of conditions within male infertility, and obviously one of them that I'm interested in is Klinefelter syndrome. So today, I'm part of the previous talk where we talked about all the different disciplines in the multidisciplinary clinic and center that we've started at Hopkins. And then I'll also be doing a session a little bit later, or right after this, I think, with some of the adolescents and whoever will want to ask any questions kind of off camera and possibly without parents there. So when I try to think about how to design or plan this talk, I think one of the big challenges is that I'm talking to lay people, but then at the same time, many of you are your own type of medical experts just by virtue of the path that life has given, and then also just chatting with some of you in person, turns out you're also, many of you, medical specialists in various different ways as well. So making a talk, I did kind of come up with something that's not too basic and not too complicated, and my hunch is that it's going to be both, despite that. So what I try to do is kind of have some technical stuff in there, but also have the very simplified take-home point as well for some of these slides. So, and obviously, we're here to answer questions and discuss as well. So, with that, on that note, we'll get started. This is what I started to present earlier. So again, the remarkable thing about fertility and Klinefelter syndrome is that about 10 or 15 years ago, wasn't even really on the radar for anyone as an option. And these are just some of the landmark things that have happened over time to make this happen. And let's see if this has a laser on it. Maybe not. There we go. And so you can see these various landmarks, but the first time that sperm was taken out of the testis and used to cause a pregnancy was about 16 years ago. And so what I want to do today is first just give a basic introduction to male fertility in general. So in a normal male, what's at play, and then we'll talk about some of the ways that things are different in a Klinefelter man or an XXY man. So we'll break it up like this, and it'll be pretty quick. So in terms of the endocrine system, Dr. Zeitler also presented and showed there are three main glands that are involved in the reproductive endocrine system. And these include the hypothalamus in the brain, and then just a centimeter below that, the pituitary. And so the hormones come down from the hypothalamus to the pituitary, and then they travel through the bloodstream to reach the testis. And this is just a little cross-section of the testis showing a tubule inside where sperm and testosterone are produced. And so one thing I wanted to emphasize is when you look at a testis, what is inside? It's a bunch of tubules. So it's people always wonder, what's inside when you do a surgery or you dissect through it. So within each of these tubules, called seminiferous tubules, is where spermatogenesis or sperm production happens. And actually between those tubules, outside of them, but within the testis, is where like the Leydig cells are, and these are the ones that make testosterone. So looking at what we call a cross-section through this circle is what it looks like when you cut through a tube, right? So this is a cross-section of a seminiferous tubule. And within that you have Sertoli cells, and these are the ones they're also called nursing cells. They nurse sperm as they develop, and so they are important in spermatogenesis. And then Leydig cells, as we said, they're outside of the circle, right? So the Leydig cells are outside in what we call the interstitium, and these make testosterone. And importantly, the impetus or the stimulation to do that is from LH, again made by the pituitary. And then finally, we have the important part of this, which is sperm. And so these are called germ cells. And what happens is, as they mature, they start out on the outside as a type of stem cell. So they're called spermatogonial stem cells. and they move one layer by one layer of maturity in towards the middle until finally they detach from all the support cells, and they move through that tubule ultimately to come out in the ejaculate. When we look at the endocrine system itself, so before we kind of looked at anatomically where they are, but looking at where they are made, and this is a pretty simplified version. Everything I'll show you is a little bit simplified, but actually pretty good knowledge if you can swallow all of it. So the hypothalamus makes what's called a gonadotropin-releasing hormone, GnRH, and that stimulates the anterior pituitary to make LH and FSH. And as we said, those go through the bloodstream, stimulate respectively the Leydig and Sertoli cells, and then that causes testosterone production. And a really important aspect of testosterone in fertility is that it's critical for Sertoli cells to do their job and for sperm to be produced. So without that testosterone contribution, then you won't get proper sperm production. So it's really both Leydig and Sertoli cells at work here. And then besides just causing sperm production, in most in most endocrine systems in the body, there's some kind of feedback. So the brain knows how much is being active or how much is working within the body. So these are the feedback mechanisms in this system. And again, there are a lot of other smaller branches of the way things feed back, but I'm kind of giving you the main cycle here. So Leydig cells make testosterone, and that itself can feed back on the pituitary, but also it is changed over to estradiol. So if you think of male and female hormones, all men have some estradiol, all women have some testosterone. But it's this enzyme aromatase that does the conversion. So it converts testosterone to estradiol. And then that gives what we call negative feedback back on the original glands. So while these were making LH and FSH, this kind of tells it, okay, it's working, you can kind of keep it at that level or not keep boosting it up. And then similarly, there are some feedback mechanisms from Sertoli cells back as well, and there's another thing called follistatin that the pituitary makes, but probably not pertinent or necessary for this conversation. Moving on anatomy-wise, not too much I want to dwell on here. The reproductive tract is just the long tract where the sperm travel after being produced within the testis. And in our situation, the most important thing here is obviously the testis. The primary process, as Dr. Zeitler mentioned, is what we call primary testicular failure. So finally, again, we're talking about normal man evaluation and treatment. So usually what we do is we do a history, a detailed history of causes that might be contributing to infertility, exposures, other things in their history. Obviously with Klinefelter men, we have one good reason there, but it's important still to take that history and make sure there aren't any other things that are working against us. And then do a careful physical examination anatomically, and then certain things that can be associated with infertility. And then of course the semen tests to make sure, are there no sperm, are there a few sperm, are there normal sperm? So all these things make a big difference in how we're going to move forward. And then finally, some various hormone studies to know how the testis is functioning and how that whole cycle is working that we just went over with all the hormones. So that's all the normal cycle. So what's different in the XXY men? So first thing is, as we said, in testicular failure, is the size of the testis. And so this is just a graph showing, this is the median of most normal men as they age. So going through puberty here, and then at the adult stage, and then in testicular volume. So in most men, it's around 20 cc's or milliliters. But you can see that in most Klinefelter guys, it kind of just follows a little bit of a bump here, and then doesn't seem to progress past that point. And this is showing what they end up as at an adult stage. And this is fancy stuff that can take years and years of practice, and it's certainly not even my specialty, but I can show you what in general this is showing. This is showing normal slides of, normal testicular tissue versus Klinefelter patients at different ages, so fetal, childhood, etc. So at gestational week number 18, you can see the main thing to note here is that these germ cells, as we saw on the other slide, are the ones that turn into sperm, and it turns out there are fewer of those cells in the tubules of a XXY male. And similarly here, you see less of these cells kind of moving towards the center, the dark germ cells within the tubules. And then as they go through puberty, we start to see what's called hyalinization. It's just a deposition of material within the tubules, kind of replacing them as opposed to the normal development of sperm, et cetera. And then finally, in the adult stage, you can see there actually aren't even as many tubules here, and what we have is more of the Leydig cells, which used to be those cells in between the tubules on the previous slide. So in terms of hormonal changes within the male, again, this is the normal male. Just going to simplify it and take out a little bit of these feedback mechanisms, and then look at an XXY male. So there are a few things kind of working against us when we think of an XXY man. So one of the things is, and we haven't quite elucidated exactly why or how, but there certainly seems to be more conversion of testosterone to estradiol in these boys and men, and that we think is responsible for the growth of breast tissue in some of these men. So whether it's the total testosterone and actually the ratio of testosterone to estradiol working, those are all various factors. And then another problem is when we talk about testicular failure, we think of Leydig cell dysfunction, Sertoli cell dysfunction, and germ cell. So those are the three cells that we kind of went through on the previous picture. So if the Leydig cells aren't working, then obviously that's another reason your testosterone will be decreased. Another thing that Susan Howell mentioned earlier was that the androgen receptor itself may not function the way we would expect it to in other men. So she talked about the CAG repeats on the end and how that's inversely proportional to how much function there is. So if they mostly have really long CAG repeats, then they may not have really well-functioning receptors. So that means that the same amount of testosterone in this patient may not have the same effects on the cells in the body versus a man with normal androgen receptor. There we go. And then again, if we talk about Sertoli cells not working, that's going to be a hindrance when it comes to producing sperm. And then what happens is, since you're getting less response from the Leydig cells and the Sertoli cells saying everything's working great, these two hormones, the LH and the FSH, go up. And so this is, as we mentioned earlier, called hypergonadotropic hypogonadism. So hypogonadism meaning low testosterone, hypergonadotropic referring to the cause of it being that it's primarily within the testis, because clearly the brain is able to make the LH and FSH. So I think the bulk of my talk today will come down to the effects of various medications on fertility. Just because that ends up being the essence of it, right? Because we're looking at trying to optimize our chances of getting sperm, and I took this medication, are my chances nil now? I took that medication, and what should I be on? Should I be on a combination? All these types of things. And I think most of my time in the office with Klinefelter patients and families ends up being discussing hormones and how they work and trying to help understand that. So that, I'm not sure if that was supposed to happen that quick. Okay. Well, so first thing, we'll just go through a few medications. So here's testosterone. So if you give testosterone treatment, we're talking about what we call exogenous testosterone, meaning from outside the body. So those are the gels, the shots that you can get, the pills that dissolve underneath the skin, and in Europe, some oral pills that they're not yet approved here because of potential for liver toxicity. So I'm still working on those in the US. But at the end of the day, this is testosterone that your own testes did not make. And what happens is that joins this testosterone in your bloodstream, and that ends up causing you to have more negative feedback on the rest of the system. So the hypothalamus and the anterior pituitary think, oh, okay, we got plenty of testosterone, so we are going to not pump out as much LH, and even FSH is affected. And so when you have less LH and FSH being produced, you get loss of stimulation of the Leydig and Sertoli cells. And obviously, as we said, those are critical for making your own testosterone and critical for making sperm. So as I said, I was going to try to make it so that we can kind of do it in a complicated way, but also I tried to just kind of sum up the take-home points on the bottom of these slides for anyone that'll be helpful for.
So Klinefelter's obviously has low testosterone, and you said increased estradiol. Is that correct?
Yeah, in general, there's more conversion of testosterone to estradiol.
So are there any like aromatase inhibitors?
There are, yeah, and we'll talk about that.
Okay.
Yeah, good question. You should be treating us. So clomiphene citrate, that's another one that we frequently use for infertile men in terms of modulating hormonal therapy, modulating the hormones with therapy. So in this example, we have clomiphene, and what it does is it blocks the negative feedback from estradiol. So what happens is then the hypothalamus and the pituitary, their thermostat kind of gets changed because they were thinking, oh, that we're getting this feedback and so everything's going fine or whatever level it is. But now it blocks that feedback, so the pituitary and the hypothalamus think, okay, we need to make more and push out more LH and FSH. And that's exactly what happens. You get more LH and FSH production, and that increases your testosterone level. Obviously, in a Klinefelter man, if there still is increased conversion to estradiol, that could continue to happen in this case. Okay. So there are other ways to try to stimulate your own production of hormones, and so we've already talked about working from this level. So now, we can try to replace these. And so the way we do that is with what we call gonadotropins. So LH and FSH are a class of hormones called gonadotropins. And so HCG, or human chorionic gonadotropins, can stimulate Leydig cells. They bind the same place and can cause stimulation. Usually we use this for patients who, for example, may not respond to clomiphene because the LH in these patients, as we talked about, is already elevated. So with the HCG, it's almost like a really strong kick to try to stimulate the testes to make testosterone. Similarly, there are some medications that can mimic FSH in the body. So there's recombinant FSH and human menopausal gonadotropins, and so some of the same principles that we talked about with the other medications apply for these. All right, and moving on, so an example of a aromatase inhibitor would be anastrozole and also testolactone. So here, as you had suggested, we can block the aromatase, which blocks the conversion of testosterone to estradiol. And so your estradiol goes down, your testosterone goes up, and so you can imagine the negative feedback also goes down. And so in these patients, we typically see increase in LH and FSH as well. And so all in all, these sound like some pretty good overall effects, right? So the only downside, or the main downside, is we don't have great data on really long-term use, and also we know that it is important to have some estradiol. So blocking it down to undetectable levels for a lifetime, or for time periods to be determined, which we don't really know exactly, can have other effects. And the most concerning of those is loss of bone density, osteoporosis, fractures, things like that in adulthood. So again, going through the advantages. So yeah, this is great. We have increased testosterone to estradiol ratios. We have increased testosterone levels and decreased estradiol levels. We're preserving the LH and FSH, in fact, stimulating them a little bit. And so we're continuing to stimulate the testes to make their own testosterone and sperm. And so the big role here is, it could be protective when we're using it with other medications. So sometimes we'll give HCG and anastrozole, or men who have been on testosterone. We can try to protect their sperm function or the testis function with an aromatase inhibitor. So some of the disadvantages, really, like I said, the long-term question marks are the biggest things. Yeah. So a lot of people say, okay, well, so what should I use? What's the best one? And I think what I tried to mention in the other talk is that it's really an individualized approach because everyone's coming in at a different stage with a different baseline situation and with different goals. So putting all those things together, the age, fertility concerns, their current hormone levels, what they've already tried medication-wise and how they responded when they tried those, their relationship status and where they stand with regards to trying to build a family, how long they've taken different medications. But like I said, there's still a lot of things we need to determine how to coordinate this with the timing of attempted sperm retrieval, both in adolescence. Am I blocking you? Can you guys see? And how to kind of coordinate those things to optimize our chances, best combinations of medications, and then obviously trying to find better medications and investigational things that will stimulate the testis in other ways.
Have these also been studied for introducing puberty?
You know,
Preventing the onset of puberty?
yeah, some are definitely, and then probably Nicole and maybe even Dr. Zeitler might be the best ones to answer the data on those. I mean, I've definitely seen various medications in association with inducing puberty, et cetera, but I'm by no means kind of the expert to comment on it or say what's better than one another. Yeah.
Because it seems if you increase the testosterone, that would tend to push the onset of puberty or not?
Yes, yeah, that's absolutely.
But most of the time at the beginning of puberty, like with the testosterone with puberty, boys with XXY go into puberty naturally. It starts naturally on its own, so you don't have to induce it. But then what happens is that as the testicle, the pathological changes happen that he showed, that your testosterone levels start to go down and your LH and FSH go up. So it's then when you kind of start to replace the testosterone. And so some people will do aromatase inhibitors and testosterone, but you're not inducing puberty. You're kind of helping to complete puberty or finish puberty when you're starting testosterone in adolescence.
I know age is a big variable, but approximately what age are you looking at there?
Anywhere between, I would say the average is 13 to 15.
When you might consider introducing this if you're going to?
Yes.
Right.
When your body kind of, usually puberty in male starts around 12 versus 11 or 12. It depends a little bit on the family. Of course, there's a lot of variability. And then again, puberty usually starts kind of naturally, and it's a year or two before, your body kind of says, hey, I can't quite keep up in testosterone production. And so, now some endocrinologists will wait and wait and wait and wait, and that's why we're doing some of these other studies. But in general, our practice, where we watch for LH to increase and we watch for testosterone to kind of, start to halt, and say, okay, it's time to start. The majority of the time when they start is about 13, 14, 15 years old. A couple years, a year to two from when they kind of first started puberty signs, having pubic hair and, body odor and all that kind of stuff.
Right, and some people will use, the clinical situation, and depending on what your goal is, some people might just follow the labs and try to be able to tell what's going on in the testis based on LH and FSH levels, and you might time your treatment with those types of things. But again, as she said, inducing is not usually the problem, but kind of sustaining and keeping it going is the goal for a lot of people. Go ahead.
With all those different options, it sounded like, with the exception of the last one,
Anastrozole, huh?
Now it just has the risk of the unknown of the health risk. If you're going to choose the other option, it sounds like you're going to have to make a combination.
Yeah, so most commonly.
That's the only one that will be by itself.
So in Klinefelter men, anastrozole is the most common medication that we use, and it's just a matter of plus or minus in combination with other things. And part of that is depending on how much, because as we talked about, all men are kind of going to be on a different part of the spectrum. So it depends heavily on also what their own natural production of testosterone is, and how much of that is getting converted to estradiol in them.
So I know that the timing of the retrieval is still an unknown, but with what looks like diminishing returns as they get older, you have, we have a 12-year-old, so we have the luxury of kind of not being behind the 8 ball in terms of, treatments that have been done already. Are you recommending earlier retrieval? If you see a 20-year-old, you collect sperm then, or?
Sure. So I don't really think of it as my place to recommend. I think of it as my place to counsel and decide with a patient, because it's a hard decision to put a 12, 13-year-old through surgery. It's one thing to consider, and I'm just to play devil's advocate. Yes, from a fertility standpoint, I probably would favor that, but not every man ends up wanting, getting to that stage and everything, and every family's in a different financial situation, preserving sperm, preserving tissue for so long and whatnot. So I kind of view my role as trying to talk through the pros and cons and how to make that decision for every patient.
So, but at what age what do you see in terms of diminishing returns from the surgery? Like, is there a certain time where it goes from being 50 to 60% successful to being 20% successful?
Not so much, but at the same time, I can't say that we have enough data to make that conclusion. Like, most of the conclusions we have, we're putting together findings from all these sorts of random different studies and trying to put them all together with all the data to say, well, this suggests that this, but it's hard to say this is the way it is. Yeah. And we'll touch on some of that a little bit more here as well.
Just one more question on medications. You're talking about for fertility. Are you, it's not like a stupid question, but are you talking about, so if I'm older boy doesn't produce sperm at all, these medications will induce the production of sperm? Or if they don't produce any sperm at all, would those things not work? I guess that's where I'm
Right, so
a little
it's
confused.
by no means a guarantee of producing sperm.
But it's chance.
Right, so what
Okay.
we're hoping is that by manipulating the hormones and we're going to squeeze every little bit of productivity out of the testis that we can.
Even if there wasn't any to begin with? Or is there always some to begin with?
No, so
No. Do you
there
understand
may
what
be,
I'm
but
saying?
certainly we have plenty of people where you check and you don't find any. Does that mean, even that doesn't mean that there's none in there, right?
Okay.
So it's hard for me to say, is there always some or not? Will we always find some? Definitely not.
But that's what these medications are doing. Are they trying to stimulate somebody that doesn't produce sperm?
Or that does,
Low levels.
we're trying to make them make more.
Make more. Okay.
Right. If somebody doesn't have any of the precursor cells to sperm, they're not going to make sperm. So they need those germ cells, those spermatogonial germ cells, all that kind of stuff. So if those just don't exist in a man, we can stimulate them all we want, but they won't make any sperm.
Right. Like I
So,
sure designed it, but I sure like both of our children were XC.
sure.
So, but I mean, he doesn't have Klinefelter. We just happen to have a son out of it that has Klinefelter. So I mean, we are familiar with some what you're talking about from a different.
Sure. So I guess in summary, the goal here is to optimize the things that we know.
It sounds like you've been coming a long way since even we had the procedure 11, 13 years ago.
Okay.
Because I don't recall some of these options.
Yeah, and there are a lot of variables that it's hard to
Right.
kind of know exactly what was going on at that time. So.
One other, just a quick question. Regarding stem cell research, can stem cells ever be programmed to become sperm cells?
Yeah, we'll touch on that as well.
Okay, because many years ago we did say cord blood, and it's still frozen for whatever future developments there might be.
Sure, exactly. That's the key word is might. Exactly. So, so as I was saying there, the key to all this is really just deciding for that given patient. This thing is, if the battery's losing me. So, in terms when it comes to management, right? So, at a glance, about 5%, as we said, will have sperm in their ejaculate already. This usually won't be enough to get pregnant naturally, although it has been reported that this has happened. Because in theory, it just takes one sperm to meet the egg and cause fertilization. But the vast majority in the ejaculate will have no sperm, and that's what we call azoospermia. Just because there are no sperm in the ejaculate does not mean that the testis is not making any sperm at all. It just means that it's not making enough to be making its way through the pipes and to actually be seen when we look under the microscope at an ejaculate sample. So because of this, we try to go into the testis and directly find sperm. That can be used with assisted reproductive techniques, and these are the main types of procedures that we use. A little bit on cryopreservation of ejaculated sperm. So for that population where there are some sperm in the ejaculate, this is sometimes possible. So you're asking, do all of them have it at some point? We don't really know, but certainly not every single person we check that we get a sample at the time of puberty, not everyone will have sperm in the ejaculate. We don't know if we collected from that same person every month from the first time they had an ejaculate through their age of 20, would we ever find one? We don't know the answer to that, unfortunately. And so in terms of timing of attempting preservation, it can correlate with lab values. So a lot of times, if somebody knows before they've reached puberty that this is their intention, then you can kind of follow labs every 4 or 6 months. And once you start to see that rise in LH and FSH, then that can be kind of your trigger point to say, okay, now's our shot to do a procedure to try to retrieve sperm. And then, as we said, testosterone may affect the success, but as we'll see, there's some mixed data on how reversible that is and whether adding anastrozole to that will prevent it. Unfortunately, everything is pretty small trial and just kind of reviews of previous patients at this point. Another thing that I've run into a challenge is a lot of times these boys and young men aren't quite at the emotional maturity as their counterparts in their classroom and things like that. So they may not be able to go in and make the sample and things like that when you want to. So it just adds another challenge into the overall approach. So in terms of sperm retrieval procedures, so TESI is testicular sperm extraction, as we wrote out before. And then microtest is a version of that where rather than just taking a few, so this is a testis right here, and these are a few tiny openings in the testis with those tubules kind of protruding out here, And so rather than just taking a few pieces of these tubules somewhat randomly, in a microdissection, testicular sperm extraction, we'll make an incision along the entire equator of the testis and open it up kind of like a book, and since they're tubules, you're not really damaging anything. They just kind of open up and come apart. And then working under the microscope, you can try to find the tubules that look better. So in this picture, you can see how out here, there are a lot of kind of very stringy, unhealthy looking tubules. But what we have found over the years is that there are small pockets or individual tubules which might have remained productive and continue to make sperm. So the goal in microdissection testicular sperm extraction is to find those tubules and to leave behind as much of the other tissue as you can so that it can continue to make testosterone, et cetera, subsequently. So this pretty much summarizes the differences there between these two. So in terms of optimizing it, again, we talked about the effects of testosterone on treatment and how it suppresses testis function, but we don't have any real trials or studies to show how reversible is that, how much does it, if and how much does it worsen our chances of finding sperm when we go into the testis. So different options we touched on as well before. You can stop and defer the testosterone treatment until after sperm retrieval. Sometimes people will try to just stop it around 6 months before you're planning on doing a retrieval. Do we know that that's the best time? No, we have no way to know that for sure. Alternative medications, like we discussed, and then, like I also mentioned earlier, you can titrate, So another approach is to titrate your testosterone so that you're not giving so much that it's suppressing your LH and FSH down to, bottomed out levels, but so that you still have a borderline high LH and FSH level that is still giving some stimulation to the testis. So it's just a way to give testosterone, but try to not give so much that it's having detrimental effects on testis function. And then again, like we said, effects of anastrozole or HCG, these don't suppress testis function, but we don't have any great data. And when we do use HCG or clomiphene, oftentimes we'll use it with an aromatase inhibitor due to the increased estradiol. So most of our guesses, or our best guesses of how things work in these patients, or success rates and medications, the effects of medications, most of it truly comes from what we call non-obstructive azoospermia patients. And yes, Klinefelter patients in general are non-obstructive azoospermia. What that means is azoospermia, no sperm in the ejaculate, but from a non-obstructive cause. So if you think of a man who has a vasectomy, he has no sperm in the ejaculate, but that's from an obstructive cause, right? So they're similar patients, but it's important that we know, or we acknowledge that they're different population. And a lot of these studies are what we call non-randomized. Some of them are what we call non-controlled, and it just means that there's a lot of bias, and there's a lot of it's harder to tease out what exactly is having the effect that's giving the result that we're then making conclusions based off of. So in some, though, with these various medications, we do have literature in different regions showing mixed to moderate benefit from these various medications when it comes to increasing your chances of finding sperm when you do a microdissection, testicular sperm extraction. And that's kind of comes to what I was saying when we're just trying to optimize our chances, because maybe if there's X level, we won't find any when we go in there, but if there's that much more, then maybe we will find some when we go in. Okay, and then another thing is predicting the success of microtesting, and this is a big challenge. It's very important to be able to counsel patients other than just give you, well, everyone like you, or everyone with this karyotype, this is your chance. Within these NOA patients, looking at FSH, something called Inhibin B that was on an earlier slide showing the feedback, and then ratios of different hormones, whether or not they respond to medications, their age and testis volume. So it's been really tough to find any of these to be a great predictor to tell you, oh, you know what, since your FSH is high, our chances of finding sperm are only 5%. There's nothing like that. But as you mentioned earlier, the most consistent thing is that the age does seem to be a factor, and that just suggests that there's a kind of slow and steady decline in function over the years. But again, we like to have studies with large number of patients that are, these perfectly controlled trials, which is hard to do when we're dealing with a small population, actually coming to the doctor to get this done. And then also, when a lot of times people don't want to be in a trial where we're going to say, well, do you mind if there's a 50% chance that we might do this and 50% chance we might do that? And that's what randomization is in a trial. So a lot of times people aren't really up for that. They kind of know what they want to do, and that's what makes it hard to get the perfect or the most optimal data to make conclusions for some of these things.
Do you have any trials going on?
Right now, not yet at Hopkins Clinical. We're kind of doing a lot of basic science stuff and hoping to make it translational soon. But okay. And then so that it kind of begs the question, as we said, if there is a slow, steady decline, is retrieval better in adolescence? And so it's important first to note that we're not talking about thousands or barely 100 patients that we're making conclusions from. So it's limited data, but in general, the retrieval rates seem to be similar to older patients when we look at a broad scale. Does that necessarily mean that maybe we're getting more sperm in the younger patients, things like that? Those are all possibilities that we don't know exactly the answer to at this point. So some people might look at this and say, oh, we got to do it earlier, and some people might look at it and say, why would we do it now? And that's why, as I was saying, I think it's a very personal decision. The theoretical advantages, one is cryopreservation of spermatogonial sperm cells. And then once you've done the procedure and frozen your sperm or your tissue, then also that might give you the kind of the freedom of choice when it comes to what testosterone treatment you're going to take or what hormonal treatment you're going to take subsequently. For example, we think that injection treatments, what they do is they kind of give a real big high boost of your testosterone, and it suppresses your LH and FSH more. So those are something that men might want to be on, but we kind of try to discourage it because we think that is more detrimental to testis function. One thing actually Dr. Tartaglia mentioned this morning is looking again at testosterone treatment alongside with anastrozole and trying to find sperm retrieval rates. So coming out of Dr. Schlegel's group up at Cornell recently, and again, this is not a big study. This is 10 patients, and it's not even a trial. It's a review of patients that they've had in this specific scenario. So again, it's important to try to shrewdly use data and information that we have and not extrapolate it too far, but at the same time, we like to try to use it at least to counsel patients and tell them the way we think things work at this point. So the important thing here is that, as you'll see, most of these patients were in the same age group, about 14 to 16. They ended up deciding when they want to do procedures based on their labs and how they changed over time. And the important thing here is that they took testosterone treatment with gels as well as an aromatase inhibitor over that time, and they kind of titrated it to keep their testosterone above around 350, I think. So it's certainly promising that they found sperm in 7 out of the 10 patients. So this is, again, just a piece of the pie, or a piece of the puzzle for us. Also, it's unclear exactly how we can apply this to adults. We don't know for sure that we can now feel safe giving testosterone and anastrozole to adults at a time, and whether it's going to help or whether they'll have the same rates, et cetera.
Do we know if any of those are mosaic, or if they were all...
Those would all be non-mosaic
All
patients,
non-mosaic.
yes, yeah. So the role of spermatogonial stem cells. So this kind of theory comes a little bit from cancer patients as well. So in cancer patients in childhood, a lot of times they'll get chemotherapy regimens that wipe out their sperm cells. So even the progenitor cells, the spermatogonia and the spermatogonial stem cells, if those get wiped out, then you're not going to make sperm again. So some of this research kind of ties in with that topic. So the thought is you could take a little bit of tissue from the patient before they get chemo, and then keep their stem cells aside. And then later, once they're through all their treatment, you could try to repopulate those cells into their testis. One key difference is that those patients otherwise had a pretty normal testis. So that direct approach may not be a great option for a Klinefelter man, where, as we saw in those slides when we took a cross-section and looked at the histology in the testis, they don't have a normal testis. So just putting these stem cells back in later may not be the solution. But one other thing that could be helpful is in vitro maturation. So that's taking these sperm cells and trying to give them this factor and that factor and all these different things to make all the molecular changes happen in a petri dish, so that what started out as a type of stem cell ultimately becomes an actual sperm that can be used to inject into an egg with XC and cause a pregnancy. So again, this has been recently done in mice, not yet in humans, but it's anticipated, which is far from a guarantee, but it is certainly promising, within about a decade or 10 years. So, again, that kind of counseling comes down to an individual and kind of their thoughts on whether they even believe in doing that or whatnot. So just something to keep in mind when discussing options. So in general, right now, when we do this, it should be only on research protocol, and we're still getting a few of those things going at my institution. So really quickly, probably, was anyone here not at the one earlier where I talked about reproductive technology and all that? Okay, so we'll probably just skip. I just thought you'd be lost without knowing that once the sperm is retrieved, it's not something that you can use very simply just by injecting it in the female partner's uterus or anything like that, but that it does take some pretty complicated and sometimes expensive techniques, and it varies a lot by state based on insurance coverage. But these, as we talked about earlier, are the techniques that are used mainly ICSI for Klinefelter patients to cause a pregnancy. So I just wanted to show a couple of, So I just wanted to show a couple of cool or exciting things that we hope will be able to help patients. So one of my collaborators at Hopkins is kind of a legend in the field named Barry Zirkin, and one of the things he's looking at is how to stimulate testosterone production within Leydig cells that are failing or aged. So this is a very, again, simplified theme of a Leydig cell. So this is a Leydig cell, and this is LH binding the LH receptor on the cell. And so this is kind of the yada, yada, yada. A bunch of things happen, and ultimately stimulates cholesterol to go into a smaller structure called mitochondria. And within that is where a lot of the sex steroids get made, and it gets converted to something called pregnenolone, which ultimately becomes testosterone. And so, again, this could be over our heads and doesn't need to be dwelled on too much. But one thing he's looking at is what's called TSPO ligands, because TSPO helps cholesterol and pushes it along into the mitochondria to start making testosterone. So, so we think that with Leydig cell failure and aging, it's not a problem of just not having enough LH or things like that, but it's partially just the response to LH and the LH receptor and some of the pathways after that. So as you saw in that previous image, we're trying to bypass the receptor and some of the pathways after that. So So that would stimulate testosterone production. And so you can see in some earlier data, so this is a control where it's just a no treatment type of situation. This is LH, stimulating the testis to make testosterone. So this is testosterone levels. And it's important to note, these are cells from rats grown in a petri dish, so still a few steps away from real life. And then these are these two TSPO ligands stimulating testosterone production in these cells. And so interestingly here, this was statistically different, so meaning the aged cells did not respond to LH as well as the younger cells. And then whereas with these, they weren't statistically different, so there's less of a gap between how the aged cells work compared to the younger cells. So it's promising things that we're hoping eventually will be things we'll be trying to have other ways to stimulate the testis. One other pathway in here, so just to make it simple, all this we know, we already talked about, so this is the only new part. So, interesting, Dr. Singh earlier mentioned immunity and infection and testosterone and things like that. So similarly, infection and inflammation can stimulate something called the COX-2 pathway. We've all heard of some of those medications like Celebrex and Vioxx and things like that, so they work along this pathway. And when that inflammation causes this, it actually blocks TSPO, which ultimately helps transport of cholesterol into the mitochondria. So if we can try to block COX-2, then we can kind of block this blockage. So COX-2 inhibitors are also something that he's looked at recently with some preliminary data that's pretty promising. So, and then finally, we have a colleague, Sabra Klein, who's also looking at immunity and infections and testosterone, and we're trying to piece some of these pieces together as well. So in summary of everything we've touched on so far today, so we reviewed normal versus XXY testis function and the effects of hormone treatments both in normal men and why it might be different or different considerations in XXY men. We talked about the approach to medication options and then some of the clinical and basic science research directions. So just quickly, I think all of you guys already saw in terms of our Klinefelter Center, these are the main specialties we have here in our team. And that's about it. So it's open to. So we can just talk any questions or just chat again for another 10 or 15 minutes if there are. Sure.
When you did that, when they isolate the sperm, so as I understand it, like half of them would have maximum Y or 2 X's rather than just one in a Klinefelter's mouth. Do they separate that out before they do in vitro?
So it's interesting, different studies show different things. Some of them show that, like a huge fraction of them will have the wrong number of chromosomes and things like that. Though when you look at the ultimate mature sperm, or not fully mature, but closest thing we're going to get to it, that a much smaller percentage of those have abnormalities. So in general, usually, we don't have any great way of testing it in one sperm without killing it, although people are working on it. But in general right now, probably most people have not gone on to do genetic testing otherwise, but there's something called PGD, or genetic diagnosis prenatally. So in that instance, people can take a few cells and just check the embryo before it gets all the way to the point where it's implanted in the uterus and things like that. And they can do genetic analysis on that. And increasingly people are interested in doing that just to check and make sure that it has a normal number of chromosomes, and you can check for a few other things as well.
Isn't that, and it could be different now, but isn't it slightly not very conclusive through genetic testing?
Probably depends for what you're testing it for.
For chromosome disorder, because I have frozen embryos that
Uh-huh.
they've done that on, and was kind of encouraged and discouraged. And I mean,
Okay.
made our own personal choice.
No, so when I mean what you're testing it for, I guess it would meaning.
Well, I
are
had
you
a Klinefelter's child, so I wanted to know if
Sure.
the embryos I had a genetic, dysfunction as well.
Sure.
Before
I'm
they
probably
put
not the
it in.
best, since I'm not the actual one doing that. I don't want to.
Oh,
I don't
okay.
want to counsel wrong. Nicole, are you more familiar?
You know, I work in Fragile X where there's sometimes that's one of the options that parents choose, and it's really improved. I mean,
It has.
the technology that you can get off of this one cell that they pluck off, they can really, I mean, they can test for Fragile X. For X and Y variations, it's pretty, I mean, really for a whole extra chromosome, it's a lot easier to do that. So if that's the question, I would trust
I mean,
it.
it's kind of irrelevant now, I'm just
Right.
wondering about technology, because this was 11, 12
I
years
would
ago.
do it now because, you know, yeah. I think if you're going that far through all the procedures,
Right.
you might as well, and you have options of embryos, you know, you might as well know which ones seem to have the healthiest,
Right.
which are the healthiest to implant.
I think at the time we told it was like 40% accurate, which to me was
Yeah,
not
it's
very accurate.
Yeah, no, definitely. At this point.
But that was like 11, 12 years ago, so that's good to know that it's an option.
Sure.
And what is the ratio of, let's say you didn't do any of this with your fine father's child, you're talking about, this is all preserving sperm ahead of time, pretty much everything that you talked about, correct?
No, I mean the things that I
Or you
discussed
can
also
use
are,
all none of
yeah, I
them.
mean in adults those are all the
Okay.
considerations as well. Yeah.
So if, let's say, we decide not to do anything with our adolescent child. or-
Yeah, which is common.
And also some people don't even find out until they try to get pregnant, you know, they don't even really have.
Exactly.
Are these things as successful as with adults as they are with?
Yeah, so you know, in general, again, that's what I was touching on. The success
hard to
rates aren't
give
aren't hugely different.
They're not usually different.
Exactly. But at the same time, we're not talking about huge studies that we have to make that conclusion. But again, they're not
It's-
so
but like you
they're not
said,
so
a
overtly
child
different.
through something that
Yeah,
we're
yeah.
making a decision for them.
Exactly, and then there are the theoretical advantages that I mentioned. You know, maybe we're getting better sperm, maybe we're getting more sperm when they're younger, and then the whole question of whether that family or child is interested in stem cell cryopreservation. So certainly, when all those things are possibilities as opposed to certainties, then that's why some of my patients will decide, you know, I think we're going to wait and I'll do this
Let
later
them decide,
if I want to have kids later. But other people feel differently. So. Yeah.
Well, Santando said that if we were to do cryopreservation at this age, that we don't even know that it will be viable sperm when he's ready to have children later.
Are you talking about ejaculate, or are you talking about testis? Sure.
But so,
Yeah, you know,
is there any difference of what would have the more success rate? Is there any studies that even show that if we do this at a teenage year, that it will be, if he wants to, 20 years from now, have a kid? I mean,
so you know, again, and everything we talk about here, we're kind of extrapolating data from this population to that population, you know, and just saying, well, we don't have enough for this population, so let's kind of apply it from this larger population. So, but you know, most more recent data, kind of modern era data, when it comes to testicular tissue or testicular sperm cryopreservation, suggests that the chances of success with those sperm later are not much different. You know, possibly better, but certainly not statistically different from using fresh sperm. So I don't think that saying freezing the sperm is likely to kill it and make it not usable later.
that's what his opinion was. He
Sure.
thought that was worthless to even.
There was a time, you know, for quite some time where it was just accepted as fact that fresh sperm was the way to go, and that it just, you know, after with frozen testicular sperm, you know, it's just not a good idea or not an option. The biggest kind of catch or drawback is, and there are pros and cons to doing things each way. So when you do freeze sperm, then later on, if there aren't that many in there, you know, you have to go through and find it, and that can be a challenge. But usually it's not usually if you saw enough there at the time of freezing it, then at the time of trying to thaw it, you'll find it as well. Certainly there have been times when we've found extremely little or things like that, and they kind of make a decision on what they want to do in terms of keeping it frozen for many years and things like that. Also, you know, there's a whole other aspect to this, which is the number of procedures you're going through. So in adults, when we're doing this, we talk about frozen microtesty versus fresh microtesty. And so when you're talking about conditions where there are very little sperm in there, then a lot of times fresh microtesting is preferred because mainly, what if you're only able to find 1 or 2 sperm in your whole attempt, right? Then if you freeze those, there's some technologies to try to put them in these kind of microcapsules and be able to find them later, but the catch is if you freeze them and it's difficult to find later, things like that. So you want to just go ahead and use it right then and there. But then with that comes the fact that if you freeze, you might be able to freeze multiple vials, and each vial might be good for one round of IVF ICSI, whereas if you just use it right then, does that mean that the next time, and even the success of IVF is, around 50% to 66% depending on ages and of the female and other factors. So one thing that becomes a question is, are you going to have another microdissection testicular sperm extraction for every round of IVF? And again, that's a personal decision and it has a lot to do with finances and what you're willing to go through.
I suspect that doing research that this is a potential way to go, or is a successful way to go, I would hope that if they see that's the case, that medical insurance companies would say, this is the less expensive cost for us by doing
Sure,
this
yeah.
now than expensive procedures later.
Right, and that's a whole other conversation trying to convince insurance companies.
You don't really
Right?
take the smart way, at least
Yeah.
from my experience.
Excuse me.
Sure.
I guess I just wanted to share with the parents that are asking these kinds of questions that I know a 14-year-old boy that had a testicular biopsy and successfully has cryopreserved. I also know a 15-year-old boy who did the same thing. I'm willing to bet they were probably among the 10 that were in the study
Okay,
that
sure.
someone showed earlier. But our son, who was 16, did have sperm, in his ejaculate and all that, but he adamantly refused to do the testicular biopsy. And I know there are.
But he had sperm in his ejaculate.
He did, but.
Did he
we didn't-
preserve?
We didn't
Okay.
get it to the cryopreservation
I
plant
see.
in
Okay.
time. So just so these parents of these younger ones that are 12-ish or whatever, that's there. It's there. It's a possibility if you're in the right place at the right time, or if you have a child who's willing to, go through the procedure, which I hear, by the way, is no big deal. Because of the 2 boys that did it, they said, well, they were a little bit sore, but one went to a Broadway show that same night.
Sure.
For 2 weeks they couldn't carry their backpack around school. So that's,
Yeah.
if that helps.
In general, it's a very safe and straightforward procedure. It's not like a major abdominal surgery or anything like that. And but at the same time, surgery should not be taken lightly by anyone. So.
Also, like, emotionally explaining it to them would be more of my concern. At least
Sure.
mine's from really 11, so we're talking a couple of years from now, like, how do you explain to them why you're doing this?
Sure.
And making it
So one last question. I'm actually supposed to be in another session in about 30 seconds, so go ahead.
To make it quick, some people are giving testosterone shots to prepubescent boys, like 6, 7, 8. And I know one person that actually the behavior and the condition of the person has improved significantly. Based on what you're saying today, that doesn't sound like it's a great idea if you have reproductivity in mind.
Yeah, and they're giving it with shots. Yeah, so again, that's like in a sense, like that's a different population, 7 and 8 compared to 10 or 12 in the peripubertal stage. So again, we can make a best guess scenario, and in my best guess, yeah, there's definitely potential to knock things down in that sense, but we don't know for sure. I think that that if that is kind of a new trend coming up, it hasn't come to the point where those kids are at the point where we'd be seeing, that this is what happens when you do that, to be able to comment on it.
Thank you.
All right, thanks.